Hey guys, today on the Practice Biopsy podcast, we're going to be meeting Dr. Reed Faldet. He's a dentist who was able to purchase a practice for around $200,000 that was producing 600 and grow it to a $2 million practice in just a few short years. Today, he's a multiple practice owner. Let's see what we can learn from Dr. Reed Faldet.
Making it happen, and we so passionate. Right. With dental training, growing your dental practices every single day. Gotta keep rising, be a better version of you. We call it Kaizen. Yeah, practice biopsy. Going up, no stopping. Yeah, practice biopsy. Let's go.
Hey, Practice Biopsy, I've got Dr. Reed Faldet here today, and he is a great dentist in our community who is gracious enough to offer some of his time to talk about how he tripled one of his practices, and he's actually got two practices now. The second one followed a similar trajectory. So many of us have had a stagnant dental office for a while and thought maybe we've maxed it out, or maybe we know that it still has potential, but we haven't quite figured out how to scale it and grow it. Maybe we are thinking about buying a practice and it's kind of a middle of the run practice, not really big one, not really small, and it's plateaued for a while. And we ask ourselves, if I buy this practice, can I grow this practice? That's what we're going to talk today with Reed. Reed, say a brief intro about yourself. Where are you from? Where do you practice? And how long have you been a practice owner?
Yeah, sure. So thanks for the intro there. So I graduated dental school from the University of Iowa College of Dentistry in 2019, and I bought a practice right out of school. I kind of teed it up for myself my D3 year, kind of knowing where I wanted to go in practice. And I wanted to go to an area where I knew that there was enough demand. And so I kind of went to an area where there's a good dentist to population ratio already, and then also a decent amount of older dentists that would be retiring. My goal was to do an acquisition and not to do a startup. I just wanted the peace of mind that came with buying a revenue stream rather than having to grow it from zero. So bought a practice right out of school. A year later, had an opportunity to buy a second one, bought that. A year after that, we outgrew both of our spaces and then had to do two ground up builds. So we built two 9-up practices at that time, identical, but in two different communities about 20 minutes apart. So that's where we sit right now. So we started, the first practice we bought was maybe doing $500,000 of revenue, and quickly got that up over $1 million that first year, maybe even a little bit more than that. The second one was around 600,000. The combined revenue of both now is just over 3 million, maybe 3.2 million this year, with just two doctors. So that's where we're at now.
Nice. So this all started with a post I saw you make on social media. And you mentioned they were like two big things that led to the growth that you had. One was increasing patient volume, and two was maximizing revenue per patient. Okay. So you talked about one of your points was generating high demand. What things did you do to generate high demand that weren't previously being done in the office before you acquired it? Okay. So kind of tell that. So, because there's a lot of dentists out there, they buy a practice that's doing 500,000 or 600,000 a year. They're not sure they can grow it. How did you grow it?
Yeah, so first I would just say if you're evaluating a practice and you're looking at its revenue potential, you have to just start with the simple things like active patient count and looking at the breakdown of revenue per procedure type. So if you know that $600,000 revenue practice is really high on the prevention and hygiene side and pretty low on the restorative side, you know that there's some underdiagnosing happening, which gives you some built-in hedge right there that you can probably grow it, right? Beyond that, it's can you get the new patients to organically grow the practice and use marketing tactics to grow the volume that way. But I would say just like the low hanging fruit was I came into an older practice that the dentist did his own hygiene, paper charts, analog film. And so you instantly just kind of inject some of the technology and focus a lot on treatment plan presentation and case acceptance, because the revenue per patient isn't about necessarily diagnosing more, which it could be, right? If you're getting lazy with your diagnosis and you're not calling out the things that you're seeing, it sure can. But the biggest part is treatment acceptance. And so getting people to say yes to treatment. And so that's the easiest way to focus and generate revenue with just the patient base you have. So before you go into growing that patient base.
So pulling a lot from like the existing hygiene pool. So you're doing hygiene checkups, exams, and you're finding work in there to maybe a higher level than the previous dentist was. It's a big variable that helped you grow. So walk me through that. So like you have a hygiene patient, you're the new dentist there, you're a new face to them. They're used to seeing the old dentist. What is just your way of speaking, a sample case presentation that you might give to a patient? You see maybe some teeth that could use some crowns, maybe some teeth that need to be restored that the old dentist wasn't diagnosing. Walk through, and how did you like establish yourself as the new face when they had the old selling dentist who they trusted for a long time?
Yeah, I mean, it starts with building that rapport, but also it's coming from a place of proof. Like, here's this picture of this large alloy with a crack through it, right? And the tooth's getting a little symptomatic. It's easy to have those discussions when you can blow a picture up on the screen, and on top of that, really focusing on co-diagnosis with our hygienist, right? So if the hygienist is trained and knows exactly if they're calibrated to what I'm treatment planning, they're going to know that they can kind of front load that with the patient, warm up to the idea of, hey, Dr. Reed might recommend a crown here or some fillings here, or talk about why you should replace this tooth here. And they cover all that before I even step in the room. And that's what I focused on most. It was getting my team to talk about treatment as well as I can, if not better. And so by the time I come in, they're really warmed up to the idea. And then I'm just kind of rubber stamping it, right? And driving home the point. And then from that point, like bringing up to the front desk, and the front desk, and again, just kind of reiterate why, what's the importance, or you could call it treatment plan coordinator, whatever you want that front desk checkout person to be. But they're the ones that kind of drive it home and close it up with the financial aspect as well. So you could talk about, there's so many different ways to talk about case acceptance, but
Oh,
that's kind of
absolutely.
the general framework of it. Yeah.
From a leadership standpoint, a lot of the times I've seen in practice acquisitions, the conventional wisdom is don't change anything, don't change anything, don't change anything. You obviously changed things a lot because you tripled the practice in a very short period of time. So, what is your perspective on having buy-in from the team as they see you doing things differently? Like, wow, the old doctor was doing it this way, Dr. Reed's doing it this way. That's pretty different. Did you have resistance? Do you have the same team you had when you took over, or is it a new team now?
Yeah. So there's pretty much no original people that are there.
I pretty much assumed that.
Yeah. So there
Talk
was.
about that transition because a lot of people in my group who follow practice biopsy, they're have acquired a practice or they want to acquire a practice. So talk about that transition and the fact that almost none of the original people are still there. Say what that's like. Paint the picture for the new grad who wants to buy a practice, who wants to grow a practice.
Yeah, so there's no doubt, I would say for sure that first like month or two, right? You definitely want to get a lay of the land and not just go in there and rip off the Band-Aid and start like going crazy. But you'll quickly see whether the people in they're in that practice are going to share your vision. And you can start to share that vision with them, what you're trying to do. You don't just unload stuff on them, but over time you warm them up to the idea of these changes and kind of chip away at it, right? But ultimately you'll find out that like some people don't like change. Most people don't like change. And the more you change, the more likely you are to kind of force them out, even if you don't want to.
Yeah.
And so it's stressful. There's no doubt about it because when you first take over, you think that you need these people or you need every single person, and that Sally, who's the face of the office, right, who always answers the phone, if she leaves, all the patients are going to leave. It's just not true, right? Like the main reason they come or they will come and continue to come is because of you, the doctor. And so just know that even if the support staff do leave some of the favorites, that ultimately, like, it's not going to create that much patient attrition. But it is stressful. There's no doubt about it. But the nice thing about every green person you come in is you get to kind of train them how you want them trained. Like from day one, they're going to think like you, and you set the standard instead of trying to roll back what the previous person was doing. So
With your attrition of staff, just as a new owner, I want you to kind of put me in your headspace. Like, how did it go? Did they come to you and say, Dr. Reed, I quit? And how did you take that? Or did you go to them and say, you know what, it's not working out. We're going to go in a different direction. How did that go as a new owner?
so ultimately let me think. What's pretty much always happened is there's some kind of escalation, right? Of like you kind of have these verbal conversations, right, over and over again. Then you have to get a little bit more closed door. So my progression is this: a lot of verbal prompts, right? When the verbal prompt isn't getting there, you sit down behind closed doors, right? That's where you have the more serious discussions. From there, if that doesn't work, then it's a write-up where everything is written down exactly what's going on, what needs to change. Usually it's at that point where it either takes a turn for the better or they decide to leave. And a lot of times they leave. And that's okay with me. I'd rather put the pressure on and see if they develop and grow into the person I need them to be, or they leave.
If they
And
can
I'm
rise
okay
to
with either.
rise to the challenge that you've set for them.
Correct. Yeah. So they filter out themselves. And then the more people you get that think like you and want to be a part of that team with like a high standard and high energy, the more that everyone else kind of comes in and filters themselves out pretty quickly because the rest of the team starts setting the standard.
Right. Another thing that you talked about as far as growing the practice, I mean, tripling your practice in that short period of time is really amazing. Another thing that you talked about was optimizing your treatment delivery. You said, let's see, maximizing efficiency by streamlining your operations, using templated scheduling to reduce gaps and keep a full schedule. Can you talk about that?
Yeah, so I wish I would have done this earlier. That's one of those things that it took me a little bit longer to come to. I think a lot of dentists traditionally schedule like um, let's schedule that crown, for example, or those three fillings or whatever. And then someone says, well, how much time do you want for that? Right. And then
Mhm.
you're like, oh, 90 minutes, an hour, whatever. So what we do is we make every day look exactly the same, pretty much, where we have major blocks, minor blocks.
Block
So
scheduling.
block scheduling, that's essentially it. And so it works out really well because every day feels about the same. And so without even looking at the schedule, I know what my next procedure should be. And then it's just a matter of filling it. And so it doesn't really stress everyone out because I tell people that the production that's on the schedule is enough, right? Like that's our goal right there already. So we don't have to worry about anything else. But naturally, what happens is you fill up that schedule, limited comes in with same day treatment. And so it just kind of layers on more and more, but we
Mhm.
know where we can handle that versus it getting thrown into the worst possible time. So block scheduling helps a ton. People inevitably say, why? But what if I don't fill that block? Then I say you have a demand issue, right? That's what we were talking about
Then you
is
go back to demand.
yes. So I love to create so much demand that it's like there's so much constraints on the practice to deliver efficient clinical care that it forces us to deliver clinical
And
care
are you doing
efficiently.
creating that demand more through marketing or that demand more through just more higher volume of treatment planning during recall?
Both. I mean, you want to pull every lever you can. So and you also want to target the patient base. If you're talking about new patients alone, we
Mhm.
try to target a patient base that's going to have a higher revenue per patient need, right? Like so, an
Greater
older
dental
dental.
need area.
Yes, yeah. So you're going to focus on like we market a ton to denture patients, not because I like to make dentures, but because I want to pull all the teeth before we
Mhm.
do those dentures, right? Because that's where the greater part of that revenue is, and then implants on top of that or whatever. So yeah, a lot of it comes from focusing on the demographic that you want to serve on the marketing side, and then also doing a really good job of selling treatment to your existing patient base. That's what creates the demand. Then when you have a couple months where you're booked out now everyone's trying to figure out how can we get these patients in because we care about seeing them. We care about getting them whatever they need as soon as possible. And so your staff and team come together to create that efficient clinical protocol.
How do you like to do your marketing? Are you doing Facebook, Instagram, mailers, Google SEO? What do you like to do for marketing?
I mean, all of the above,
Yeah. Do
really.
you
Like
have
I
a
just kind
favorite?
of, I set a budget. We do it. We have some community outreach stuff that the team can participate in. It's kind of a set it and forget it for the most part. And then every now and then we tweak things.
Yeah.
I'm not by any means a marketing expert. So that's, it's nice. I wish we could have even more new patients than what we
Yeah.
do, but
So
it's
safe to
enough.
say, I mean, if you, like you said, if you're not by any means a marketing expert, but you still have a lot of demand, a lot of new patient flow, you're in an area that like needs a dentist, obviously.
Yeah, so like we don't have crazy new patient flow. Like I would say per office, since we have two offices, I'd say we average maybe 30 new patients a month,
With
right?
two doctors at each,
No, just one doctor at
one
each.
doctor at each. Okay, yeah. 30, so
That's
that's
not
pretty standard.
it's not anything crazy. That's what I mean. We don't put a ton of marketing into or a ton of dollars into marketing because
Okay.
that's sufficient enough.
Mhm.
But we could probably crank that up if we wanted to. If we were
What
gonna bring another
what type
doctor.
of what's your breadth of clinical offerings that you have? Are you doing endo, implants, ortho? What are you doing?
Pretty much bread and butter dentistry with a lot of extractions and bone grafting, but I don't actually place implants.
Mhm.
I work 20 hours clinical a week, so I'm full enough doing bread and butter. If I were to bring in, or we were to bring in another associate, another doctor, then likely I would maybe shift my focus to being a little bit more on the specialty things. But I just like it hasn't, just the necessity hasn't been there yet. Like I
Yeah.
can't imagine layering on another specialty procedure right now.
Right. Um, when it comes to just more structuring and growing the practice, I know that during a lot of acquisitions, the new owner will try to renegotiate fees with insurances. one, I didn't even ask you yet. Are you a fee for service or an insurance office? Two, if you are an insurance office, did you have the PPO fees renegotiated?
So I would say we're more fee for service.
Hmm.
We're in network with like two insurances. Everyone
Right.
else is out of network, so predominantly fee for service. We don't do the classic thing where you make the patient pay beforehand and then have the
Yeah.
insurance reimbursed. We file insurances for everyone, but we're predominantly fee for service or private pay.
Okay. So primarily, did you evaluate so taking that from that gear, many acquisitions with an older doctor, they've had their fees at the same level for like 2 decades.
Mhm.
Did you reevaluate the fees and did you change the fees when you took over?
Yeah, so we did. We changed them. We kind of ratcheted them up slowly. So like we didn't day one just jack everything up. But then I'd say we probably had to create like 15-20% fee increase.
Yeah, so about a
For the
15 to
first,
20% increase, just
yeah,
slowly over the time. Slowly over the
probably over
course
a
of
year,
like you said 2019. So
probably
it's
two
been a couple
years.
years.
Right.
Yeah.
Yeah, probably 2 years. About 10% a year is what we did. But we
Okay.
probably did, I think we remember we did like 5% in a quarter, another 5%. So we didn't completely shock everybody.
Hmm.
And I would say don't even be scared of that. Like half of our patient base is private pay, like out of pocket, and they seem to like accept it, especially when you're bringing on more technology and they see that, right? You have more of a modernized practice or whatever. They're going to see that like, okay, like there's a reason why these fees are a little bit higher, or they ignore them altogether. They don't
Hmm.
remember what they paid 6 months ago for a cleaning.
Did
So
you have to invest in new technology? Like what sort of new technology did you get? I think you said you upgraded. They were still like film and old stuff.
yeah. Yeah, so within the older buildings before we moved, I think I've seen pictures of what your practice looked like or the building
Yeah.
you took over,
Yeah.
right? It was somewhat similar, very small. Like the one practice we took over had two chairs, and then I basically put a third chair into like a closet, right?
Hmm.
Essentially a closet. But since then, like since building our new offices, scanners, CBCT, intraoral cameras. There's big monitors in every room, like just the classic stuff that you would see in a dental practice.
Yeah.
Nothing too wild.
Nice. So the original practice, that's doing like $1.82 million dollars a year currently. That one.
Yeah. Mhm.
How many operatories are in that one?
So we have it's potential to have nine, but in that one we have seven equipped right now.
Seven equipped. You're using all seven, and what is the distribution of how you're using the seven in terms of doctor chairs, hygiene chairs?
Yeah, so it's basically the office is split, like where everything is centralized, sterilization, supplies in the middle, and then we have a hygiene wing and like a doctor wing, right? That's kind of how it works.
Mhm.
And so the doctor side has four chairs and the hygiene side has three. And so we have two hygienists that work three chairs. It's kind of how we do it in that office. I work four chairs. It just depends. Like I mainly work out of three, but then like, oh, we got that one more. I put them
You have
in
your
four.
overflow. What does your
Yeah.
workflow look like? I know you do blocks, so you probably know it very well. What do your blocks look like in general, working out of four chairs? I have a 4 out practice, so we have two for hygiene and two for me. Some days
Yep.
I have three for me and one for hygiene. But what's your workflow like working out of four chairs as the doctor? Hygiene aside, just four chairs for a doctor. What does that look like?
Yeah. Yeah, so it might look like like I said, I probably only use that fourth chair maybe twice a day or something like that, maybe three times a day for something quick. But a lot of times think of it like a checkerboard a little bit, and I
Mhm.
can always send you a template if you want to see it. But
Yeah, if,
it's
if
kind
you
of
send me
like
something, I'll post it like when we post this in the group.
sure, yeah, I'm happy to share something. So like I said, I have major blocks and minor blocks. Major blocks are 2 hours, minor blocks are one, and then we have overflow. Or emergencies 30-minute little short ones. And so I and my start of my day is two majors double booked next to each other with usually like an overflow, which is like either a crown seat or whatever. You could
Mhm.
go denture adjust emergency. And so I'm starting usually two crowns or two bridges or something like that
Okay, so
simultaneously.
you've got two crowns you're starting simultaneously. There's only
Yep.
one of you, so how does that work?
So I have two assistants. I don't know in your state if you can do expanded function assistants where they can
No,
take
but a lot of
impressions.
states do. So just talk about your workflow. Okay, so
Yeah,
two
so
crowns next to each other. It's 8 o'clock.
yep.
Let's start the day.
This is a key thing. Like my hygienist numb all my patients, so I don't numb
Mhm.
any patients. So that's big. I come into the room, they're already numb. They already have the template done or their pre-scan or whatever it is. I'm just stepping in, saying hi, and starting to prep the tooth. As soon as I'm done prepping, I jump over to the next room and start doing the same process again. Sometimes if the tooth needs a buildup, I'm coming back to room one again because now I've prepped the assistant has placed the cord, it's isolated, it maybe even be etched, and I'm going to do the buildup. Then I'm flowing back and doing it the same thing in the other room. So it's just staggered, but I'm doing them simultaneously. And the patient always has an idea of why they're waiting for the next step. Oh, we're getting heme control, or we got to wait for this material to set up, or whatever it is.
So
And
you
then in
just
the
find the
meantime,
natural breaks in the procedure, and that's when you go work on the other one.
correct. Or I flow to see an emergency quick and then I flow back. And so it's just a matter of having everything really tight with your assistants and not wasting a single step during the
So,
day.
so clinically, something I heard in there is you like to do your different dentists do this different ways. You like to do your buildup like at the end. So you like to pre-crown prep the tooth and then do the buildup at the end, as opposed to remove the old restorative material, remove all the decay, then do a buildup, then prep it down. You like to remove everything, prep it, and if you need more structure, then you do the buildup and then
Correct.
refine the prep.
Yeah. And usually there's not much refinement needed
Cool.
because I pretty much almost finished it at that point. So
Nice.
yeah. So that makes a big
Um,
difference.
I saw that in your post too. You talked about maximizing the skill set to the top of their license of your team members, and you have expanded function dental assistants, you have hygienists, so they're really doing a lot for you. Um, with expanded function, are you guys doing scanner? You guys are doing scanner, right? Not PVS impressions.
Well, we've done PVS impressions for a long time. We just got a couple new Trios scanners, so we're working those into the
Can
workflow right
expanded
now.
functions take final impressions?
Yes, they can.
They can take
Mhm.
finals. Okay. Ours can't. We don't have those in Michigan.
That's a
But,
bummer.
you
That
know,
makes a big difference.
um, what would you
So
say? Go ahead. Go ahead.
we'll go.
What
So
would
I
you
was
say are some other impactful variables to, like, you're talking to the younger version of you. You're like, hey, Dr. Reed, I know this practice only does 600,000 a year. We're going to get to 2 million. Here's the secret sauce. This is what you've got to do. Like, what are you going to tell younger version of yourself?
I mean, the number one thing is like pour into your team because it's a team sport. Like you can't do it by yourself. Like it doesn't matter how good you are. If you're short an assistant, if your assistant can't do what you need them to do, like you're gonna fall on your face. It's the same thing with your hygienist. So I just think of it, it's a team sport. Like really pour into the people that are gonna be doing it with you, that are gonna be in the trenches with you, because without them, you're not gonna get where you want to go. You can't produce $2 million of dentistry yourself without a good team around you. So that's probably number one. I probably was a little too much of I'll carry the team on my back and do this all myself. And I am that way still a little bit, but I'm definitely more cognizant of how reliant I am on my team members. So that's probably number one. Number two is just being like really good at discussing treatment with patients because that's going to probably be your number one ROI is getting patients to say yes to things. Because it's just like you can have every new patient you can imagine come through the door, but if you can't get them to say yes to treatment, your op schedule is going to fall apart. So that's probably number two.
For discussing treatment with patients, do you feel like it's something that just came naturally to you, or did you do any like studying, training classes on communication, or it just came naturally to you? What was your progression with patient communication?
So I think it came pretty naturally to me. When I
Sure.
was in dental school, I knew I was going right into practice ownership. And so I really was like practicing then
Mhm.
of being good at it because I realized how important it would be. I haven't taken any CE or anything. It's just through different iterations of talking about treatment, I've just gotten better at explaining things and kind of finding like a sweet spot. And it's not about always the exact words you use or verbiage. It's just like sometimes it's meeting the patient correctly, like knowing where they're at and picking up on cues and being able to kind of pivot and talk a little bit differently than logically to, maybe loss aversion or whatever kind of, way you need to go about it. So I'd say naturally it comes to me, but it's definitely I've gotten better over time with confidence and having done more treatment. You just get more confidence over time.
Well, nice, man. I like to
Yeah.
keep these right at 20 to 30 minutes or right in there already, believe it or not. I don't want to take up too much more of your time. I just want to thank you for coming on the podcast. You're going to see this posted in the group. If you want to chime in with any resources, any like screenshots of your schedule, that'll be posted in the private practice biopsy group, dentist, dental students only.
Sure. Sounds good. I'm
Cool,
happy to do
man.
that.
Have a good
Yeah.
one.
You too. Take care.